Can you see other people trying to join the session, Lucas?
Yes.
Okay.
There are 13.
Okay.
There are 13 participants. I can see 13 participants.
Okay. Well, I will make some introductions at the very start as other people join in. And the first thing is, obviously to everybody, good afternoon, good evening. I am not an expert in India, but I have a wider global interest in older people and public health. And that was what led me to set up what we call the Global Platform, which is a loose network of academics and experts who are interested in older people and coronavirus in low middle income countries. And over the past year, we've run more than 20 webinars and we've published over 100 short papers and blogs. And you can access some of those about India, I should say, and you can access those on our websites, and you can see the link is there. And I felt, despite the fact that I personally know very little about India, I've done a little bit of work there over the years, that given what's going on in India at the moment, it was really important that we had a session which was exclusively dedicated to older people in India. But before we start properly, I thought it might be useful to quickly try to put the Indian experience into a little bit of comparative perspective. And I think this may serve two purposes. Firstly, and very understandably, I think we're all extremely focused on our own national crises. But it can be useful sometimes to take a moment and look beyond our own national crises to see what's going on elsewhere. Previous slide, please, Lucas. I'm not ready for that yet. And secondly, I think there's sometimes a tendency for people perhaps to overgeneralize about countries like India, the global south, emerging economies, compared to more affluent countries. And I think that's not particularly helpful when we're looking at the pandemic. So next slide, please. Here are some comparisons with Brazil, which is a country I know a lot more about. Clearly, both are large countries, emerging economies, and both have been enduring devastating pandemic effects over the last few months. But what does that mean for their older populations? In terms of wider context, well, their age structures are broadly similar. Brazil's population is slightly more aged than India's. But what I think is very telling is the distribution of that population between rural and urban areas. Clearly, India is still a primarily rural society, and I think that matters. It mattered before the pandemic, it matters now in many, many ways for those older people, and we mustn't lose sight of that. It affects their lives, their well-being, their vulnerabilities in many ways. And talking of vulnerabilities, another important point to bear in mind is that almost all Brazilians over the age of 60 can expect a monthly income from the state, which is quite substantial. It's about $200 a month. And clearly that isn't a common experience for older people in India. And clearly that will really matter in terms of some of the effects of the pandemic on older people in India. And also in a similar way, over the years, Brazil has invested considerably more than India in its public health system, and particularly in areas like community-based primary healthcare services. And the effects of that could be seen, for example, in terms of much higher rates of vaccination for older people for influenza or pneumonia than you see in India. So again, you can see the relevance for those differences in the context of the pandemic. Next slide, please. It's interesting that when I look at the international media and its depiction, next slide, please, of India and Brazil, it seems actually rather similar. We spent a lot of time talking about Brazil in January and February, and then the attention shifted to India. Much of it is focused on criticizing the national leaderships, I think for very good reasons. Another similarity you see is that both of these countries have quite a lot of decentralized governance, not surprisingly because they're so big, and a lot of responsibility has been delegated towards subnational governments. And given the sizes of these countries, in some ways, partly because of that, but epidemiologically, I think it's sometimes more useful to look at separate regional pandemics within these countries rather than the overall national picture, and that's something we might see a bit of today. Next slide, please. Other comparisons are difficult to make. Clearly, wave one in India was relatively small compared to wave one in 2020 in Brazil. Wave one in 2020 in Brazil is similar to wave two, and that's not the case in India. Why India was somewhat unscathed in 2020 and not today is clearly a matter which we haven't been able to understand yet, and it is clearly very important. But beyond that, it's hard to make many more specific comparisons because, frankly, the quality of the data, especially for India, are very poor, very limited. So officially, older people make up a much lower share of COVID deaths in India than in Brazil. Okay, they make up a lower share of the population in general, but that doesn't account for the large difference in share of deaths. That could be a reporting effect, of course, or it could be a genuine effect to some extent. We simply don't know. And when we make other comparisons between the two countries, in fact, it is quite difficult to feel confident about what we're looking at. What we do know is that in Brazil since March, despite the continuing second wave, the number of deaths of older people has actually fallen very sharply, and deaths are increasingly occurring at younger ages. And that's a direct consequence of the vaccination program, which is very, very strongly, apart from health workers, prioritised the oldest old, starting with people aged over 90 and working down in 5-year age groups. It's not been perfect, but it's been relatively effective, at least giving those people a first dose of vaccine. And clearly that hasn't happened in India. Next slide, please. So these are just some very quick comparisons, which may be useful to structure some of our discussion today. There are many others we could make, including clearly the shared anger and the outrage about what's going on in many parts of the world, including in my own country. And it is very hard to look at these issues in a detached academic way. And next slide, please. In that sense, I hope that we can do something which perhaps we don't try and do on other webinars run by the Global Platform, that we don't just see this as an interesting academic exchange today, although that's important, but perhaps it's a way to try and draw wider public attention to these issues and to develop a shared urgent set of actions. So this is one part of an urgent response to what's going on in India in terms of older people. So today we have 4 expert speakers and a discussant, an expert discussant, and we hope to have about half an hour at the end of the session for questions and general discussion. Hopefully this will be an informal discussion. As I said, it's not being recorded, although we may share the recording later. But this doesn't mean that this won't be urgent or serious in tone. All our speakers are incredibly busy people at the best of times, and clearly these are not the best of times. So I'm incredibly grateful to them. And I want to make sure we all make the best use we can of their very valuable time. So just one last thing, before I introduce the speakers, my colleague Lucas will briefly tell you about how non-speakers can participate in this event, because we really want to hear from you as well. Lucas.
Thank you, Peter. Welcome, everyone. You could engage with us through the Q&A button or in the chat. I will be looking at both of them, and we will address your questions at the end in the discussion session. Thank you very much.
Thank you, Lucas. Can you move through the slides, please, to our speakers? Our first speaker is Dr. Arukya Sami, with whom I'm currently collaborating on some interesting work on hypertension and older people in India. He is head of the International Institute for Population Sciences in Mumbai. He's one of India's leading demographers. He's one of the leaders of the LASSI longitudinal study of aging in India. And he has a strong focus on a whole range of different health issues, including many papers on non-communicable disease. So I'm sure he'll have some very important contributions to make. Dr. Arukya Sami, the floor is yours.
Yeah. Share screen. Just a minute. Oh, can you see the screen? Yeah. All right. Okay. So good afternoon. I'm so delighted to be part of this meeting. And many thanks to Peter for this opportunity to speak on COVID pandemic in India, and particularly on risk and vulnerability of India's elderly population. I just thought to give you some snapshot of COVID dashboard, the numbers that we have based on WHO numbers. Globally reported 166 million confirmed cases and 3.5 million deaths. And of course, 1.45 billion vaccine doses so far have been administered. And if you look at the other estimates of mortality, recent estimates by the Institute of Health Metrics, their analysis suggests that COVID mortality could be approximately 7 million globally, more than double of what official numbers show. The India officially reported number of COVID cases is 26 million. Of the total 330 million sample that was tested, that means a positivity rate of 9%. Overall, officially, India reports around 300,000 deaths. But if you look at IHME estimates, their estimates suggest that India's death could be as much as 650 deaths. That's more than double what official numbers say. And the matter of concern is this is projected to rise to close to 1 million deaths by August. So in that backdrop, what India has done so far is just around 200 million vaccination doses have been administered so far. That covers around 14% of the population. Roughly around 50% of the population, elderly population, have received at least one dose. If you want to relate to the global situation, top 5 countries in the world, United States, India, Mexico, Brazil, and Russian Federation, together they account for half of the world's COVID confirmed cases, more than 80 million. They also account for more than half of the COVID fatalities, mortality. And surprisingly, what is important to see is that the estimates provided by the Institute of Health Metrics, Washington, that is much in excess of what the official numbers say. For example, in US, it is 55% higher. In India, it is 120% higher. In Mexico, it is more than 33% higher. In Brazil, it is 20% higher. And in Russia, it is 400% higher. So clearly, there is a lot of gap between what is officially reported and what is possible, potentially, the number of COVID mortality. If you want to relate India's demographics to this current scenario of COVID infections and mortality, India is currently home to an estimated 135 million elderly population. And elderly are really at high risk. They form around 20% of the total COVID-19 cases. They account for 50 to 60% of COVID fatalities. Therefore, COVID clearly affects the elderly population fatally, with median age of fatality around 60 years. Of course, the next most hit age group is 40 to 60 years, with around 30% of total fatalities. And those below 40 years, their fatality account for 10%. If you relate to the international data, 8 out of 10 deaths reported in the US are older adults ages 65 and older. And this is more or less similar in European countries. Clearly, the excess risk of elderly mortality is somewhat higher in European and European countries and US. Now, you may want to know how pandemic affects older people differently than other people. Over 60% of elderly have at least one chronic health condition, and 20% of elderly have at least some mental or neurological disorders. And WHO's recent synthesis shows that older people with pre-existing medical conditions such as diabetes, blood pressure, heart disease, lung disease, kidney disease, etc., they develop severe illness of COVID more often than others. So therefore, elderly are main risk group of hospital admission, severe illness, and death if infected by COVID-19. They experience reduced mobility, chronic pain, and frailty, or other health problems for which they require immediate as well as long-term care. Comorbidities tend to increase with risk, with increasing number and severity of comorbidities, contributing to further increase in the overall risk of COVID fatality. We also know that male sex and obesity and SES vulnerability are also very closely associated with increased risk of COVID infection and fatality. I tried to bring some data on health risk and chronic health, prevalence of chronic health conditions from available data that we have from last year as well as the SAGE India survey. What you can see from these numbers that you see from these charts, virtually almost everyone in age 45 has some risk condition, health risk condition. 85% have at least 2 health risk condition. 2/3 have at least 3 health risk conditions, and around half of the older adults have at least 4 health risk conditions. What are those? Tobacco, alcohol consumption, physical inactivity, obesity, high risk waist hip ratio, ADL limitations, exposure to indoor air pollution. These are the indicators that we took. And if you relate this with morbidity prevalence, India, as you know, has very high prevalence of chronic health conditions. Cardiovascular disease prevalence rates range anywhere between 35 to, among older adults, 35 to 40%. And then followed by respiratory diseases, diabetes, etc. All of these, the prevalence rates range from 15 to 20%. So clearly, older adults in India have very high prevalence of health risk conditions as well as chronic health conditions. So that is how elderly experience excess mortality, much higher excess mortality of COVID than other age groups. So officially reported numbers say that elderly have more than 7 times higher risk of COVID mortality in India than younger adults. And men possibly have 2 to 3 times higher COVID mortality risk than women. That is an ICMR analysis. Around 85% of elderly COVID-19 fatality, I mean, those who had fatality had pre-existing conditions, virtually 86. Everyone had some kind of chronic conditions, pre-existing chronic conditions, cardiovascular disease, kidney disease, cancer, and so on. In addition, you all know there was also substantial unreported COVID deaths in India in many low-income countries. Cases which are undetected, unreported because of poor surveillance system in rural areas and even in many urban areas. The other part of COVID mortality, not direct COVID mortality, but due to lack of access to healthcare for elderly with chronic conditions, timely access, or immediate, not only timely access, but also the access to right healthcare, I mean the correct healthcare. The lockdown measures also contributed to excess mortality, that is loss of livelihood, poverty, food scarcity, and so on. So we have the big picture of COVID in India. And if you relate the COVID mortality, I have some interesting data based visuals from the recent analysis conducted by the Institute of Health Metrics, Washington. They estimated daily COVID-19 deaths according to smooth trend estimates. You can see this chart visual, but you can see what started as a very low number in hundreds in early 20s in March, April. The peak of wave 1 was between July to October. That time the peak was around 2,000 deaths. That was around 3 months. And then the wave 1, the peak smoothed out and it declined. Then what you see later for wave 2, you see dramatic rise to as much as 5,000 deaths, daily deaths in April and May. What you see currently, so very, very large excess deaths, 5,000 deaths. Now, if you also look at the analysis done by IHME, COVID-19 deaths, weekly deaths Now they rank number one. Earlier, cardiovascular disease, diabetes, and respiratory disease, they were the top contributors of mortality, non-communicable disease mortality. Now COVID-19 is the number one contributor to mortality, weekly contributor to mortality. The last visual that I want to relate to you, the COVID-19 deaths cumulative scenario that we have here projected by the IHME estimate. So there was a very slow progression, reached acceleration in May, and what we see is that if protection measures, adequate protection measures, including vaccination, if adequate measures are not taken, then the situation could worsen much more. In a reference scenario, as we see now, that is the grain. So still that could take us all the way up to more than a million excess deaths. But in a worst scenario, it could take us to 1.2 million excess deaths. And if you adopt the strategy of universal mask as well as vaccination, it could be much less. The last is the IHME estimates looks more modest and bit of gold standard than many other estimates. So even the IHME estimates show that the level of excess mortality is much higher than what the official numbers say. So what India has done so far is very minimal in terms of vaccination. We have been able to administer just 200 million doses, mostly first dose, and just around 14% of the population. And if you, what the projection suggests, it's just possible to vaccinate around 40% of adults by August. And if it is just one dose, it could be around 600 million by August. So there is a long way to go. So what are the takeaways? Global evidence suggests the need to implement policies to protect elderly during this pandemic. And the impacts of pandemic threaten to last for years that may undo decades of progress on multiple fronts. The massive excess of elderly fatality can be averted and could have been averted by more targeted policies and rollout of vaccination. Elderly at severe risk of disease and death from COVID must come first everywhere, according to WHO Director General recent statement. India needs to ramp up its vaccination program to target elderly. Thank you.
Thank you so much, Dr. Rakyasamy. That was excellent, and you provided so much very useful background, and you kept perfectly to time as well. Just for people who may have come in slightly late, if you do have any questions, you can either wait until the end after all the speakers have finished, and we will have about 20 minutes or half an hour of general discussion, but also feel free during the sessions to make comments or ask questions in the chat function. Thank you. Now I would like to turn to our second speaker, who is Dr. Vinod Shah. Dr. Shah is the chairman of the Jana Seva Foundation, which he founded 30 years ago, and this has UN special consultative status. He is vice president for the Asia Pacific region of the International Federation of Aging. He's in charge of a national health line for senior citizens in Maharashtra state. They must be having a very busy time at the moment. And he has many other important positions, including being a member of the official working committee for developing an Indian national plan of action for the welfare of its senior citizens. So I'm sure he'll be able to bring a wide range of very important insights to our discussion. I don't believe Dr. Shah is using slides, but if he wants to use his own slides, he's perfectly welcome to do that. Dr. Shah, the floor is yours. Thank you.
Yeah, thank you, sir. Good morning, good evening, good afternoon to all. At the outset, I thank Peter, sir, for giving me this unique opportunity to be with all of you and these stalwarts. at the outset, I will like to pray God that Prasan should get well soon, because I was not knowing. In the morning, I had a talk with him, but he just said, I am having COVID. Actually, I had also COVID 1 month back, and now I have recovered. So I am going to talk on this long-term care, especially in India in COVID-19 pandemic. Sir, all of us will know, we know that these nursing homes are most affected in USA, in UK and other parts of the Brazil and other parts of the Europe. And we know that this pandemic has showed us how elder care facilities has failed, especially in care homes. And this is because timely epidemiological surveillance was essential for outbreak response. It was not done. And therefore, COVID-19 pandemic has a negative impact on long-term care all over the world. And we know that 42% of the total outbreak in USA is in nursing homes. And in all over the world, 19 to 72% of the senior citizens are affected in long-term care facility units or centers. Especially in Slovenia, we know that 81% of the deaths are there in long-term care unit, while in USA, 45% deaths are there in nursing homes. As such, in India, we don't have exact survey or research or thing, but the incidence of death in long-term care and units and old age homes is definitely low. It's not that high, especially in our unit in Janaseva Foundation, it is hardly 6%, but it's maybe because of immunity or whatever vaccination they have, whatever viral infections they have, like H1N1 in the past, and in the past having BCG and all. But out of, we know that as the sir said, that population of senior citizens in India is 135 millions. Amongst that, the oldest old are the fastest growing number, and above 80, 15% are the is the number. So that 25 millions are above 80 in India. So we know that this pandemic has brought about an unprecedented fear and uncertainty. So people are so afraid of this, and including in long-term care, those who stay there. So, and that is mainly because in long-term care, in all the centers, there is no infection prevention control facilities. Many youngsters are asymptomatic and they carry the disease, and they are the caretakers. There are no trained caretakers, and they spread the infection. Many have comorbidities, and many of the senior citizens staying in our long-term care unit or in Janaseva Foundation, they are frail. So they are most vulnerable to the COVID-19. So it is difficult to maintain the social distancing in the long-term care. What we always suggest, that maintain physical distancing, social distancing, and there are various types of disabilities, and therefore activity of daily living is suffered. 45% senior citizens in our institute also, they are disabled. They have visual problems or even hearing problems, and 13% of the patients are dementic. They are having dementia. Even many senior citizens, they are having 2 to 3 diseases at a time. Maybe diabetes with hypertension, with ILD, with kidney problem, so many others, even having cancer along with that. So that is the problem. And then psychological is the major thing which we have to tackle, and that is anxiety, depression. Depression is seen in almost 50% cases. Cognitive impairment, then panic mood, and because of loneliness, because they cannot contact with their parents and their youngsters outside, the current visitors cannot come and see them. They become panic, and even there are incidences of suicidal tendencies. Even in our old age home and our long-term care center, a doctor who is 45 years old, ultimately after at the end of the year, in I think in February, he tried suicide because he got frustrated because his children who are doctors and daughter-in-laws, nobody came to see him. So that's the problem in long-term care facilities. Related to this, these agitations and irritability, restlessness, emotional distress, sleep disturbances, these are very common in our all patients. And patients of dementia, schizophrenia, they are very troublesome to manage in these long-term care units. And therefore, there may be another reason like loss of spouse, insecurity in the home or in the long-term care unit, not getting pensions timely because of these lockdowns, then medicines properly, the medical advice may not be available from the experts, though it is now there is a telemedicine, and even we have 24 hours medical officer is there, but people are not happy with that. So main difference of course is in formal and informal caregivers. So informal caregivers are always in the families, and now they are tired of taking long-term care of their family members, seniors in the families, because 6 months, 1 year, continuously this is going on now, a year has passed, and therefore there is a neglect and there is a abuse also. So even in our institutes also, we take help of formal caregivers, but they are not that trained, and then still incidence of elder abuse is seen all over India in all old age homes and long-term care units up to 25%, and even in families also. So that is another thing. Now long-term care facility centers, there is a lack of what is the problem there is a lack of standardized guidelines. There is a underfunding, so government gives meager charges, then worker shortage is always there, and in this lockdown we are facing, it's a big problem. And then of course this abuse. Now what government is doing, what is done in India? In India, there is what is called as National Program of Healthcare of Elderly. And in that, there is a promotional, prevention, rehabilitation services and information, education and communication programs, IEC programs, what we call. There are regional geriatric centers, and there are separate OPDs, wards and training programs going on for the capacity building. And then lot of health intervention is done at various levels, including primary health centers, sub-centers, and district hospitals, where the beds are reserved for long-term care of the senior citizens. Even in tertiary hospital also, even geriatric post-graduation is started at many places in India. And then another system is integrated program of older people. And that is actually through that, there is a national action plan, and which includes financial assistance to such people to run old age homes and long-term care units, then daycare centers, and to run mobile medical unit and ambulance, then physiotherapy services, then giving for disabled persons some aids like crutches and wheelchairs and all. And now recently government has started helpline. So even anybody from even old age home or long-term care center also can call 14567 number and tell his complaint, so that immediate action is taken. And this is nationwide. Even the central government comes to know that in Maharashtra some person has done this complaint and that it is taken care of. So that is and that is what now we are doing. though this helpline is not launched officially, we have started working and we are helping all COVID patients and doing their counseling. As such, government has started training for the caregivers, sensitization programs in the schools and college students in order to maintain this intergenerational solidarity. And Janaseva Foundation is one of the organizations which is involved in this, all such activities. We have especially this Ministry of Ayush. And in this Ministry of Ayush, we teach them yoga. And even we give those who want Ayurvedic medicines, homeopathic medicines, and Unani and all. So this is also taken care of in even long-term care centers also. Friends, India is actually fighting COVID-19 epidemic, and that too with limited manpower. Our manpower is very limited. Doctors, sisters, as whatever required, we don't have. Our limited economy, that is another problem. Because of this vast number of patients which you have now seen, what doctor has told us, that there are more than 26.53 million cases affected in India. So with this, there are many long-term caregiver centers in India run by good institutions like Janaseva Foundation, Nightingale Medical Trust, Apollo Group of Hospitals, then this Alzheimer-related Disorders Society of India. They have 4 big centers, and under them there are so many hospitals. They take care of this dementia and Alzheimer patients. Then Helpage India and so many. Actually, Helpage India did one study in 2009, and they found that there are only 1,018 old age homes in India. But now I must tell you that this number up at the end of 12 years, that means into 1021, it has gone to more than 3,000. And in Maharashtra itself, there are almost more than 500 such old age homes and seniors long-term care units. But what is important is they are all not run by government. Government has its own limitations, but through Regional Resource Center and National Institute of Social Defense, and through the Act of Maintenance of Welfare of Parents and Senior Citizen Act, now government has started constructing old age homes in every district, and there are more than 350 old age homes run by central government under RRTC. And then all the states have having old age homes up to 40, 50 in the states at various places at taluka levels and all. Even under integrated program for older people, which started in 2015, they have started giving services to these senior citizens. And what is important is very few long-term care centers. Those who are good, they are affordable, they are accessible. There is quality care, which includes medical, social, personal aspect, and which includes preventive and curative measures. So the number is less, but otherwise others they don't have any license and they run it as it is. So in India, where urban and rural elders are left alone, children are abroad or migrated from the villages to the cities. So no one is there to take care of them in the house. And therefore,
excuse me, sorry, Dr. Shah. Sorry to interrupt, Dr. Shah. You have 1 more minute. I just want to make sure we have time for questions at the end of the webinar. Sorry to interrupt.
I think I will take 3-4 minutes more. Is it possible?
If
Hello?
you can make it a couple of minutes, just because we've got a lot of speakers, and I know we've got some very interesting participants who are raising some very interesting questions about your talk.
Yeah. So now
I'm so sorry.
So now I will come to the end. Now we have hopeful situation in India, and that is because of vaccination. But as he said that vaccination is meager at present. and we are now worried about post-COVID complications. So post-COVID complications like pneumonias and thromboembolic phenomenon and mucormycosis that has started raising. And with this, lastly, I will only tell that facility-based models are required all over the world to reduce the mortality in third and fourth wave, because in Japan they said that fourth wave will come, and in India very soon we'll get the third wave. So WHO has given guidelines therefore preventing and managing COVID-19 across long-term care services, and that is policy brief in Geneva only, and countries should act accordingly. So lastly, especially to protect long-term care centers and care homes, let us have long-term care task forces providing guidance and financial support, repeat testing of the staff as and when necessary, repeat testing of the suspected seniors, and let them be under surveillance, isolation, quarantine, and procurement of the equipment like oxygen concentration and boosting staffing level, retention of staff, minimization of infection through workforce and PPE kits, then special ways for visits of relatives with these various precautions, and strengthening the medical support of the senior citizens in the long-term care unit, and giving residents full confidence so that they will become independent and they will have a dignified life. In this, I did not tell what we do in our long-term care center at Janaseva, but if anybody asks, I will definitely tell you. Thank you.
Thank you so much, Dr. Shah. Many apologies for rushing what was an extremely interesting talk. And I think those points you're making towards the end about the need for a task force to support long-term care in India is extremely well made and extremely relevant. I'd like to now hand over to Dr. Prasun Chatterjee, who, like Dr. Shah, is himself recovering from coronavirus. And he is based at the All India Institute of Medical Science. He's one of India's leading geriatricians, as well as having a strong focus on clinical research and practice. He works on a whole range of other issues that affect older people. And for example, in 2013, he founded the NGO Healthy Aging India, which works to support older people in India living in poverty. So, Dr. Chatterjee, the floor is yours.
Thank you, Professor Peter. I have one more speaker with me, my daughter. So I'm sorry. Hello. So intermittently there will be some cough, but I will not take I think more than 3-4 minutes. I think Professor Arag Goswami and Dr. Shah has covered most of the part. And honestly speaking, we have very less data to say something, because I am from All India Institute. I speak, I can only talk on data, medical data, which has been published in peer-reviewed journal. So unfortunately, that is not there. And being in one of the premier institute, what I see that just like any other disease, elderly people also present with atypical presentation. And actually speaking, there is this story of my second attack of COVID is like that. I was not working in COVID area. We have a separate ward of senior citizen geriatric medicine. So one fellow got admitted with uncontrolled heart failure. It was like decompensated heart failure, we called as. So I was treating that patient with my team, and the day of admission we screen everyone for COVID as per protocol, but day of admission he was negative. And on 7th day he developed fever, and along with the heart failure we came to know that we did all the basic tests, but along with that we repeated COVID test, and the COVID came positive. So unfortunately, all of us who were not prepared to hear that news that he is COVID positive, because we were treating in the line of heart failure, and he developed COVID. From where he got, it is a mystery. But I'll not say mystery, because for elderly people there is always a caregiver who comes. So maybe someone from outside, maybe his family member has carried the infection, he got infected, or it was in a subtle format. And he developed COVID. I have second example. Recently that happened. The 89 years old man who suffered from COVID, who recovered from COVID. But of course, he had a lot of lung changes and some amount of fibrosis. He had UTI, urinary tract infection. So started with home care. We from our NGO Healthy Aging India started home care, which is managing mild to moderate cases successfully. And we have given respite to many people for that, including oxygen concern, because this transition from community sensitization to mild to moderate to quick shift in hospital is very, very important. So there we missed many times because of course there is a novel virus. We also didn't know much. We are learning every day. So that patient, again coming back to the story, 89 years old man, we took him again for complicated UTI. We were managing with IV antibiotic, but suddenly again his saturation dropped, and we went for CT. We saw there is fibrosis and acute changes, new changes in the lung. Again we went for COVID test, COVID positive. So within a span of 1 month time, that fellow developed twice COVID. So it is so atypical, new strain. Honestly speaking, yet to know many things about COVID. As rightly my previous speakers mentioned that we have to think a lot about this vulnerable population. I have some answer for Dr. Binasa why long-term care, because I am connected with 27 long-term care facility where we serve free of cost healthcare. I'll say good thing about our long-term care facility, why they didn't suffer from COVID, because most of the long-term care facility are survived by the donor, because these are charitable long-term care facility, run by mostly charitable organization. So once there is lockdown last year, this year also, usual donors stop coming to the hospital, coming to this long-term care center. So most of the carrier either asymptomatic, and most of the worker in the long-term care center, if I say worker or supporter or attendant, they stay 24/7. So that is also another reason. So it is always content. Even if 1 or 2 people have suffered, it has not come from outside. That is a great thing. That is the great thing. So no outsider has been either allowed or they didn't come voluntarily to serve these people. That is one of the reason that our long-term care center, vulnerable elderly people, has been saved from high prevalence of COVID as compared to any other developed nation. Regarding post-COVID complication, I must say something which has been somebody has question. Yes, we need to take care of their mental health, which is very, very important. I know there is post-COVID fibrosis, there is pneumonia, there is and I'll not repeat about mortality. Everybody knows they have the highest mortality. They have comorbidity. They have geriatric syndrome. So these are all known fact. But something which we have to take care, family member has to take care. I have a publication on that last year itself, and that was correspondence to American Geriatric Society Journal, that young generation has to participate. Where our NGO Healthy Aging India, we connect with elderly people with young generation. So we had a model called intergenerational learning, where senior citizen teaches underprivileged children, and this is a win-win situation for both. During this COVID, I have connected with elderly people with this underprivileged children through leveraging digital technology. So I am seeing those who are teaching children, they are happy, they are still within the society, they are telling me something positive. But of course, the prevalence of social isolation, depression is going to be very high. As I understand, Professor Peter, you have interest with Alzheimer's and cognitive impairment. I do also a lot of research on that. And definitely, this COVID will increase the prevalence of cognitive impairment in the older adults, especially because we are increasing fast. Our elderly people are rapidly, the growth is much faster. 80+ has growth is faster. So we are going to face, if we don't go for primordial or primary prevention or active aging for elderly people, it's difficult to control. Maybe dementia pandemic is very soon, which is knocking our door. So that is something which we have to actively work. I'm no one to comment on government policy, healthcare system, because I'm in a government job and still now. And again, because I cannot criticize based on what Professor Agunse mentioned very rightly, I cannot speak on based on newspaper cutting and all this writing, which is mostly not unbiased. But yes, I get at least 100 call every day that I don't have bed, I'm not getting oxygen till last, can you help me to get bed? AIMS was full, where even we couldn't accommodate family member of our faculty also. So that happened because there was definitely a failure in prediction, but probably we are, I'm hopeful that we are ready for next wave. We are preparing ourselves adequately for vaccination. And even we are talking about vaccination. I want to mention all of you that I am vaccinated twice. I have adequate titer, but last year I suffered, this year also I suffered, and I suffered badly. My lung had more than 60% injury and I'm still recovering. So thank you. Thanks for the opportunity, and all the best. Be COVID free, be safe. I wish for all of you and your family. Thank you. Thank you, Peter.
Well, thank you so much, Dr. Chatterjee. Clearly, you're making a special effort when your own health isn't as good as it might be. And I think you conveyed with passion and clarity some very important issues, ranging from your own personal experiences and observations in your professional practice to some very important wider observations about the situation that India is currently facing. So many thanks. And lots of questions are coming through that we will be taking towards the end of this session. I would now like to turn to our discussant, who is Aravinda Guntupalli, who's based at the University of Aberdeen in the UK, where she is a senior lecturer in global health. Aravinda is an epidemiologist who has done a whole range of different pieces of research looking at the health of older people in many parts of the world, including high-income countries and including India. She has particular interests in issues of data quality during the pandemic, and this included a co-authored paper about this issue that came out in the Gerontologist a few months ago. So Aravinda is a discussant, so she hasn't prepared a talk in advance of this session. She will be responding to what has been said and adding her own insights to what has already been said. So Aravinda, the microphone and the floor are both yours.
Yeah, thanks, Peter. All the presentations were brilliant, and I thought they complemented each other. Everyone had a really particular focus on a challenge that older people were facing in their area of work. As Peter highlighted, majority of older people in India live in rural areas. As per 2011 census, we know that 73.3 million older people live in rural areas. So before we go further in all the presentations, there was a cross-cutting theme: impact of COVID-19 on people living in rural areas. We know directly that the testing facility in rural areas were very poor. We know directly that long-term care facilities in rural areas don't really strongly exist. They exist only in few states. And we also know from the evidence we have that the COVID care facilities did not exist in many areas, especially in the northern part of India. So what we have is this, within older people, very strong rural-urban disparity, and also age disaggregated kind of disparity that we can't really understand because of lack of data. And also the other aspect we need to focus on is what Professor Arokya Swamy talked about in terms of risk and vulnerability of India's older population. His presentation really provided the existing evidence on what's happening in India, what kind of estimates are available, and what can we learn about impact on COVID-19 pandemic on various sections of society in terms of especially focusing on comorbidities. Again, as you can see from the data he has presented, we don't have age-specific data. What we can see is the mortality, how it is changing, and also how we can see based on projections that if we take the estimate of projection to be the high or medium or low estimate, what would be the impact of mortality. And what India is lacking very strongly is data on this age-specific mortality, so we can understand exact impact of what's happening. The government released, based on the first COVID wave, some data sets on comorbidities that Professor Arokya Swamy touched on, the mortality data as well from the ICMR. And what some of the government data showed is that in 60+ population with comorbidities, they had the highest risk of mortality, which is 24.6 case fatality rate, which was the highest compared to any other group. However, despite knowing, even though there are gaps in the data, and this is what we know based on the first wave of COVID in India, we still do not understand the impact of it, and we still haven't strengthened our data system. So we don't really understand the impact of second wave with the B1617 variant and what's happening with the interaction with comorbidities. Professor Arokeswamy also touched a little bit on the latest evidence available from LASI as well. And all the data sets with any comorbidity or any kind of self-reported chronic condition shows that it is directly related to age. With increase in age, we see the prevalence of diabetes, we see prevalence of CVD, hypertension, chronic lung disease. Take any chronic condition, that's what we see. So based on that, we should have prioritized older people, and we haven't prioritized it. And that came really strongly in Professor Arokeswamy's presentation, that we should really look into what's happening in India at the moment and what data do we have. Forget about the data we are not able to collect, but at least look at the latest data of older people and then look at what could happen, who are the ones the suffering most, and then think of policies in relation to that. And again, the presentation touched on some of the estimates, and we know that the government doesn't provide any data by age and sex-specific mortality or morbidity. We do have crowdsource funding page called COVID-19 India that collects some of the data, but majority of the data on age and sex distribution is completely empty. So we cannot really do any estimates, and the government's data is not really released outside for researchers. So I urge everyone who has data to release data possible so that we can do more analysis, because then Professor Arokeswamy could further strengthen the evidence that we have. And with limited evidence, we only have to focus on estimates, and the fight is about which estimate would be the closest, and we don't really have a very good database. Just to touch a little bit, going to Kerala as well, we know that Kerala is the state that has fantastic data collection. Even then, a group of volunteers collected data of mortality from different newspapers and found there was a massive gap between what the government of Kerala reported compared to what was happening. So even in a state like Kerala, where we praise the health system and the data, we have this massive problem. And that's where Dr. Shah's talk nicely moved also into the impact of COVID-19 on long-term care facilities. And we all know when COVID-19 first wave started, majority of the discussion focused on long-term care, older people. However, in Indian setting, it was not really coming across. Very few media articles touched on what's happening to older people and long-term care conditions. And there were no real guidance released by government. There was some guidance released for older people, but it didn't really focus on specific kind of policies on how to reduce the infection. And there was nothing happening even by the end of the first wave, except in Kerala, where Kerala introduced that by December, by the end of the last year, they introduced it once in 3 months. All care home residents must go through reliable RT-PCR test, and everyone working must have RT-PCR test to monitor COVID cases within care home facilities. But long-term conditions, long-term care facilities were completely ignored in the database. There was one study in Western India that showed that there was no impact at all in long-term care conditions. So we have this kind of Dr. Shah's work from his foundation showed that there was impact, but majority of the studies that were based on either media or one of the research paper from Western Indian study showed that there was no impact because they emptied the care home by 25%. But again, that puts a question on why did they leave? Who were the 25% that were released out of care homes? Was it a force? Who was responsible for providing care? So all those different monitoring systems have to be strengthened. And we know from the presentation that, as Dr. Shah maintained and mentioned very clearly, that we need more data to understand the impact of who is coming in, who is going out, what's happening, what is the impact on mental health, Alzheimer's, and all other aspects. So back to the same point, we need to have more data so that we can have stronger evidence and build very stronger policies on that. And Dr. Chatterjee's presentation again moved to very, very important aspect of clinical care and some of his own challenges. How he got COVID, he doesn't know. And this is what many of my friends and family members also say, that we have been sitting at home, we don't know how we got it. So some it's such a difficult, complicated situation, especially in a clinical setting where you have long-term condition and care provision, and that makes it really, really challenging. And your experience, unfortunate experience, and also how it unfolded in your settings explain how many people were surprised with COVID within their own long-term settings as well. So despite being prepared, despite have vaccinations, checking, always one case entering is sufficient to increase the vulnerability, and it tells that we need to work more on it. And we haven't touched a little bit on we have touched in the presentation, Dr. Chatterjee touched on the post-COVID complications like pneumonia and fibroids and various other aspects. But one of the things that's emerging, and again, we don't have any data, is the mucormycosis, the black fungal disease. That's one of the big new epidemic coming in India, where 5 states in India have declared that it is a big problem within the 5 states, and they don't have sufficient injections. So again, we have absolutely no data on how many older people. Is age a risk factor? We don't know. We know that diabetes and chronic conditions could be a risk factor. So again, we need more data, and it's really good to see the contrast of 2 presentations. Dr. Shah said there was an impact, and how Dr. Chatterjee said the impact was. So that's what is happening in India. Different settings have different experiences, and what we need is a bit more comprehensive study of all India level, so that we understand where there are less risk and where they had higher risk, and what happened, what were the lessons we can learn. And that's what is missing at the moment, lessons we can share, so that we can get prepared better across different settings. And then we moved to Mr. Nidesh's presentation that gave excellent summary on how state government of Kerala responded to COVID-19 crisis. His presentation started with poor infrastructure, and we all know that's one of the massive challenges government is facing, especially at the moment in terms of oxygen as well, hospital beds, and that's one of the requests. All of us here who attend this presentation with some Indian connection will know that the main WhatsApp or Twitter or any kind of Facebook question these days, and in the last 2 months, has been, do you have this injection? You could exactly see where the demand is moving to. So initially it was all about hospital beds, then it moved to oxygen stayed for a long time along with hospital and ventilators, and then now moved to the black fungal infection related injections as well, which is currently not available. So the demand kept changing, but we don't know who had the demand and how the demand is changing by older people as well. But Nidesh's presentation really showed how good food distribution system, various aspects, including use of ASHA workers to understand multimorbidities, have excellent database, strengthened really Kerala's response to it. And I saw a really excellent video of different people sitting in a room where the monitor was showing how much oxygen is available in different hospitals in Kerala. And then they could plan, as it was the live board was updating, Kerala government was planning how much oxygen is required for different settings. And they had really state-of-the-art facility and they never faced any kind of oxygen challenges compared to other states. So there are so many lessons we can learn from Kerala, and that's an easy statement to make, because to follow Kerala model, it's not one day switch something. To follow Kerala model, we need to uproot and strengthen the health system from bottom up, and that's going to be a very challenging task. Nidesh talked a little bit about government's role and was critical on it, and also we have to mention, while talking about Kerala, that Kerala people were very pleased with the support of government on the Kerala fight and have re-elected the government as well. So the health minister was kind of role model. Everyone fondly calls as teacher. So she is one of the teachers who started the kind of, very strong fight, starting with Nipah virus and then moved to, she faced so many infectious disease challenges during her tenure, and Shailaja teacher was becoming an icon in India, kind of a role model sort. So it's really interesting to see how we can learn lessons from each other. But I just want to conclude and say a few points that while there are lessons to learn, we are not learning lessons, and that's the sad aspect of it. It is political at the moment, and we can't take the big P or small p of politics away from any debate and discussion at the moment related to COVID. And I said this before and I'll say it again, history will judge us because this is a massive pandemic and people's lives are at stake and the suffering is happening in front of us. And by focusing on the small p and big P repeatedly during this, yes, it is important to focus on politics. It's important to stress the lack of any kind of policies we need. But the point is it should not take the center stage. People's lives, that P should come into the center stage, not the politics of P, because at the moment it feels like everyone is so annoyed and upset while fighting with various aspects of it, and we are not coming together. And in the past, India ever faced such a big disaster was in the 1918-21 influenza epidemic, and back then we could blame the British for government, then the settings for not having data. But independent India on its own first time is facing the biggest crisis, and we can't put finger on anyone except ourselves. So I think being united, having strong data sets, learning from each other, continuing the debate, having transparent data is the only way forward to fight it. And at the moment, there is very little information, very little discussion, either by government or on media in relation to older people. And we need to keep saying that we need to have more data, more focus on older people. Thanks a lot, Peter.
Well, thank you, Aravind, and I think you've done a fabulous job of both drawing out some of the key themes, the crisscrossing themes as well, and adding what I think are some additional insights which are incredibly valuable to the session as a whole. The way I'm going to try and handle the rest of the session is, firstly, any participants, I know a lot of people have asked questions in the chat. If you do have questions, if you could raise your hand as a participant, then I will identify you and I will certainly prioritize people who are participating in the session who haven't had an opportunity to speak themselves yet. While we're waiting for that, I will just make a couple of very quick general comments and ask one question of my own, just to give other people time to organize themselves some questions. And clearly, there are so many different aspects of this that we could have focused on, and it's interesting to me. Partly, of course, it's because of the speakers who are participating that we seem to have focused on 2 or 3 broad aspects of what's going on. The issue of data, in many ways, has come up, including these really quite frightening projections that are coming out from IHME and even more frightening from other organisations. Surveillance, not publishing data, not disaggregating data in certain ways. We've talked a lot about long-term care, and I think often people find it quite surprising to talk about long-term care in India, but of course, people should realise that there is a huge need for long-term care, and most of it being provided by informal carers, although long-term care facilities have become much more widespread in the country. And clearly the context of long-term care in India is extremely different to the context of long-term care in most other parts of the world. And I guess we've also tried to touch on, although it's extremely difficult, especially when data are incredibly limited, to talk about varied experiences of older people in rural and urban areas and different parts of the country, people who are on either side of the digital divide, different settings, different care settings, and so at least trying to capture some of the diversity, which I think is extremely difficult to do. One thing that hasn't come up, and I just thought I would flag it and briefly invite any of the panelists or the participants even to respond to this, is what about access to treatment? Because at the moment, my impression is, I saw a study that was published a few months ago about a large teaching hospital in North India, where the average age of people who were receiving treatment for coronavirus was 30. We know that ICU units, Dr. Chatterjee was talking about his own experiences. Should we even be talking about the rights of older people vis-a-vis other age groups, or am I just being almost too precious about the rights of older people at the moment? This is a difficult ethical discussion to have. Is this something we want to talk about in this session, or are we just being unrealistic? We can raise the issue about whether older people are being treated fairly in terms of access to treatment. So I'll throw that one out there while other people think about raising their hands. And if anybody wants to respond, as I say, this session is not being recorded at the moment, so you can be as forthright as you would like to be.
Can I say something, Peter, about I think access to treatment is really, really complicated when it comes to older people, because I have seen personally various challenges. On one side, the hospitals are not looking at the age base for admission at the moment, because if somebody is in a critical stage, they might. But then when oxygen was very low and they were running out of it, I understand that they had to prioritize who gets it and what kind of treatment is provided within. So that is where we have to understand if there were some ageisms going in and saying that the risk might be higher of, for older people, and maybe they might have prioritized younger people over older people. But I also know of several rural older people personally myself. The parents, some friends or friends of friends have said that in some settings, they just couldn't go to any healthcare facility because they're not used to any apps. So to get a hospital in India at the moment is a very difficult one, especially getting an ICU bed. So how do you do it? You keep following what hospital beds are available on different apps. So first of all, older people are less likely to use apps, so they need to rely on some family members to look for it. And the other option is also to get an ambulance or a vehicle to go to a hospital facility. So all these have been major challenges that rural older people decided to stay at home. And also they're worried that if they go, they're likely to die on their own. So there are so many complexities within those, because some did not want to get admitted, some did not manage to get hospital, some did not know the negotiation. And also at the moment, networks played a stronger role than money. So people needed to have networks to get to hospital because everyone wanted to fight. And I understand that networks and being at the right time, right place was the only thing to get hospitals at the moment during the crisis. So it's really difficult to understand older people and treatment.
Thank you very much. That's a very helpful answer. One of our participants has got their hand raised, but if anybody else would just like to, of our panelists, would like to.
There are two hands, Peter. There are two hands.
Oh, we've got two hands now.
There are two hands.
Does anybody, in terms of our panelists, want to very briefly respond to that, or shall I?
I have just two quick points. One is older people in India remain neglected and vulnerable, as Ravind said. They still are a neglected group of population and remain very, very vulnerable. That is number one. Number two is, as far as this COVID crisis is concerned, there is lack of robust scientific evidence in India as far as the decisions are made in India. If, for example, if you look at US, the CDC has enormous resources and they have an excellent surveillance system, and all the decisions are based on hard scientific evidence, whereas there is a very big gap. We don't have a good surveillance system, and even for COVID also, we don't have a kind of system to collect all the COVID-related mortality and make the data available to the researchers to do scientific analysis.
Very good point. I mean, interestingly, of course, on a per capita basis, the USA has seen more coronavirus deaths than India. I think even taking into account underreporting in India, that's probably the case, as has the UK. So clearly what's going on in India is incredibly bad. But again, that comparative insight, I used the case of Brazil before, there are many other places you could compare. But what I'll do is I'll now hand over to participants who've raised their hands. And if any of the other panelists either want to come back to that question, or I will come back to it at the very end of the webinar as well if you want to provide some final points relating to your talk. So
there is one. Hello, Peter.
Oh, sorry, Nilesh. Just very briefly, yeah?
Yeah, there is one question. What are the reasons for less allocation in fund in the health sector? I would like to answer that. Can you?
Yeah, can we hold that just for now? Because I've got a list of the questions and that's on it. I just want to start with who raised their hand first. And I'm just now unmuting Selvamani, Selvamani, who has got their hand raised. So I'm sorry, I don't know your first name, but Selvamani, you should now be able to unmute your microphone. Hello, you are now live and we should be able to hear you. No, I will come back to you later. I'm sorry about that. And I will go back to a next question, which is from Jefferson. Hello, Jefferson.
Hello.
Oh, hello, Jefferson. Yeah, we can all hear you.
Okay, thank you very much for the opportunity. We have learned a lot. My question is based on that is governance and COVID, politics and COVID. We can't run from the fact that whatever policies that comes out and that need to be implemented will need to come from politicians. So I want to understand what will be the rule. Are there clear defined rules for politicians and clear defined rule for academicians and clear defined rules for practitioners in the treatment of COVID? In this case of discussion, how do we merge the role of all these three key stakeholders to have a successful implementation of policies?
Great question. Just very briefly, Jefferson, I should have asked when I brought you in, could you let me know what your affiliation is and where you're based, whether you're somebody who works in India or from another part of the world?
Okay, thank you very much. Jefferson Asari Dankwa, and I'm a student of Global Health and Management from University of Aberdeen.
Ah, okay. A student of Aravinda's, I assume.
Right.
Great. Okay. Well, that's a great question. And again, I mean, any of the panelists want to respond. Clearly, Aravinda raised the big P and the small p of this, as you know, I think it's extremely important to do. I think Vinod is unmuted, so perhaps he has some particular comments he would like to make about that, or some of the other discussion we were just having. So over to you, Vinod.
Hello.
The floor is yours, Vinod.
Hello.
Hello, Vinod. We can hear you. Do you have a...
No, no. I just wanted to tell you that he asked about these politicians and all. Of course, these politicians, they interfere and but they help also in managing such cases. Sometimes the problem is actually exaggerated because of interference of politicians. But in Maharashtra state, they have taken a lot of efforts to take care of such COVID affected patients. But the incidence is so high, especially all of you must be knowing that Pune Pune city was having once upon a time highest number of cases in the world, and that too Pune district and Pune city. So in the villages also there were many cases, and we have to have these COVID care centers in the villages. And Janaseva Foundation started one COVID care center in the villages with the help of government, and government gave us 2 medical officers also to take care of them. So that is how government definitely, without government we cannot do anything. There are so many big COVID centers, jumbo centers were started in Pune, and they were full of patients. In spite of everything, patient died on the road because of lack of oxygen.
Thank you so much. I would like to, I'm still trying to bring in one of the panelists who has their hand raised, but I can't actually get them on at the moment. I'll have one more try. We have had some very interesting questions coming in through the chat, including some interesting questions and comments from Monica and from Arvind. I don't know if either of them, I'm sorry for sort of singling you out, but I wonder if either of you would like to take forward some of those comments that you were putting out in the chat. No, I'm not hearing from any of those guys. I just want to make sure that everybody has an opportunity. Also, we have had some comments in the Q&A from Dr. Deshpande and Srinivas Pachava, making some further comments and questions. I don't know if you would like to raise your hands or if you feel that your concerns have been dealt with adequately by the speakers. No, I don't see a whole lot of hand raising going on at the moment. Well, in which case, I think what we might want to do is just give each of our speakers a couple of minutes, if they wish to take them, just to add any further comments which they feel, in the light of the webinar, they would like to make, and particularly perhaps thinking about, is there anything that we can do as a group of the people participating, the people giving papers, to try and raise the profile of these issues, to try and advocate in different ways? Because clearly we're academics, but we're also extremely concerned, and we want to take as constructive a role as we can to address these issues in India as well as in many other countries. So if you have any suggestions about what might be a constructive shared agenda that we could take forward with very specific things that could be done, and not just things we wish might be done either by ourselves or by other people, I think that would be an extremely helpful discussion to have. So I think Dr. Chatterjee, you're live, so I assume that means you've got something to contribute. Over to you.
Yeah, thank you, Professor Peter. Actually, as I mentioned in my chat box, that I have a serious patient. I need to go for VC with him. But before that, I just want to say that now we have to take the collective responsibility, especially when you have a senior citizen at home. Someone mentioned that they are not digitally literate, but I promote lifelong learning. And I know many senior citizens from rural India also, they have learned, including my father. He learned mobile technology and Facebook from my 9 years old son. So, and now he's equally, and there is no question, and there is no point in just telling that they're not digitally expert. Somehow through promotion of Digital India, smartphone is there in most of the villages, if not in every family. I will say at least 50% of the rural India has a smartphone. And I know even from my village, I'm from a very, very interior villages of West Bengal, where the students who has even dropped out from school at the level of 5 or 6, even if they are not literate that way, they cannot read much English or other things, but they know how to WhatsApp and how to see the Facebook and chat. So as I think Aravinda rightly mentioned that, and somehow we are connected, and COVID has united us a lot. People has become more empathetic towards each other. People started socializing. That is a good part. But yes, we have to prepare for future wave if it is coming, and the preparation has to be now we understood, including me, that it is your health and it is you have to take care. So that is the first priority. You have to work on your immune system. I was neglecting my health. Now like Almighty has taught me that you have to be careful about your health. It's not always work. I used to work 16 17 hours without taking care of my health, my hospital, my research, my NGO work and all these things. But yes, you have to take care of yourself, your family. And even if elderly people are staying in remote places, even if you are staying abroad, please
Dr.
take care of them.
Can I just pause you, because you made the first point you just made about digital literacy. Do you think there would be scope to get academics and experts and some people with influence together to try and establish a national movement to enhance the digital literacy of older people in India, especially in rural areas? Because we've seen how important that is in terms of getting access to the vaccine, maintaining connected to family. And I didn't know about getting access to beds. I mean, clearly it's so important and multidimensionally important. And I just thought perhaps to be able to go somewhere like the Ford Foundation, to Gates, or to a large telecommunications company, this is the kind of thing I'm talking about. And it's what's needed. And there may be a window at the moment to do that.
This is absolutely possible, Professor Peter, because that will also help, because which is future of healthcare is telehealth. So until unless they are not digitally a little bit literate, at least how to use this, telemedicine cannot be implemented in rural India until unless we are connecting them. And yes, this needs to be a movement. We from our NGO, we are starting that. We are starting in a rural village of UP where we are teaching elderly people, as well as we are starting telehealth care, because telehealth care is now we understood how important is this for especially elderly people. They are not going to come to OPD, outpatient care of tertiary care center, maybe next 2 to 3 years. We need to take care of their chronic disease. We have started that from our All India Institute. We need to take care of hypertension, diabetes, coronary artery disease, stroke. We are talking all about COVID. What about the other disease? They're not getting admitted anywhere, because we all of us, we are telling that only COVID. Usual surgery which used to we conduct in AIMS in 1 month, 2 month, 6 months, now they are getting dead of 3 years, 4 years. So all elective procedure, including cancer surgery, are really in problem. Like, so we have to think beyond COVID. But ultimately, I'll say it is a collective responsibility. We all have to be together. And unfortunately, there is no politician. There are a lot of questions to politician. So somehow, Peter, you couldn't connect them. So next time, I think you just try some administrator. Last year, we conducted a study from WHO, World Health Organization, CRO. That data is yet to be published. I am working on that data. Yes, again, I'm repeating the same thing. Long-term care people, they somehow they got the service. Rather, I will say community dwelling elderly people, they suffer most, and somehow they used to visit hospital regularly, because most of the long-term care center, what we call as old age home, has been served by doctor at doorstep, either by NGO or by government or by mobile healthcare facility. So somehow, like we have continued, including COVID, with PPE kit. Still, we are continuing service for old age homes, like long-term care facility. Dr. Binasa himself is a doctor, so he is taking care of his long-term care elderly people, So somehow it got managed. So fortunately, I'll say this is a great thing that our long-term care elderly people has not suffered, because they are really vulnerable. They are really in bad shape. We did a study in AIMS where we have seen frailty is definitely a predictor of more long-term mortality. Again, the study has to be published. So in conclusion, everybody is talking about evidence, but somehow the evidence is yet to come. So we have to wait for that. Let's join hand together and be more empathetic, more sympathetic. And instead of criticizing each other, we have to work together and do something what we can do, what I can do. So last line is, Mahatma Gandhi ji, be the change, then you expect change on others. Thank you. I'm sorry, I have to quit.
No, not at all. And I just want to invite the other speakers to quickly comment. And if you have other specific suggestions, like the one that just came out there, which I'm very happy to take forward with people, the idea of putting a proposal to a major sponsor to see if we can do something to improve the digital literacy of the most disadvantaged older people in India, I think that could be a positive thing that comes out of this. But if other people have other suggestions, that's what I'm particularly looking for, to make the best use we have of all of these people sitting around this virtual room. So anybody else? I can see Dr. Shah, you're unmuted. I don't know if that's because you have something to suggest.
What Prasann has said, it's I agree with him. Actually, we had a very good discussion, and then summing up done by Arvinda is excellent. What is important is 70%, almost 71% of the senior citizens out of 135 millions, they stay in villages. And therefore, India has to concentrate on villages. So actually in the second wave, most of the patients suffered, they were from villages, and most of the deaths are from villages. And therefore now government is concentrating on it. But still there are some lacunae which we have to explain the politicians that they should take good care, because they allow the public to come together at many places, and otherwise they declared lockdown. So because of that, the number of this prevalence has increased. But now because of strict lockdown, the number has now come down even in the villages. In Pune, where we used to get 5,000, 6,000 cases per day, the rate has come to 400. yesterday's rate. We have hardly 400 cases in a day.
Muted, we can't hear you, sorry. You're on mute, Peter.
Sorry.
Peter.
I've got a very squeaky chair, so I turn off my microphone when other people are speaking, because otherwise you would hear my squeaky chair. No, there seems to be a lot of agreement across the speakers about some of these issues, about what the priorities are. And frankly, perhaps, although we all agree that getting more data and changing government priorities is, there are fundamental structural things that we, need to be changing in India, is to some extent true in many other countries. Perhaps this proposal about a digital movement is something that we could actually contribute to, which could make a difference. And of course, it could be something which is also providing public health messages of relevance to people using that technology. So that's certainly something that I will come back to. I have to say, it will be something that needs to be led from India, but I'd be happy to contribute to that, or at least to facilitate that. Would any of our other speakers have any final thoughts or suggestions they would like to make? Aravind, you've got your hand raised, so it looks like you do. So maybe what we'll do is we'll just go round from Aravinda to Ariksami to Nidish, and then to anybody else who'd like to make any final point. I think I've spoken far too much, so that's all you'll hear from me. Aravinda, over to you.
Thanks, Peter. I was thinking of, in addition to digital, two other kind of actions we can do. One thing is, we know that media and also governments do not really provide data on older people. That makes it difficult for us to specifically understand what's happening with older people. So I wonder if we can start a letter and then send to different media agencies saying that, can you focus a little bit more on the challenges of older people, given the vulnerability being the highest? Maybe a letter or some kind of something to put pressure that at the moment the discussion very much is on younger people and also children, because the third wave is supposed to be more focusing on children. So what you see is increasingly lots of child-related COVID cases, taking away more and more even the middle-age impact as well. So that's the other thing I was thinking. And the third one I kept thinking about, and I would like to hear other people's perspective, something like a big white wall, or something like a wall that people can write their experiences, especially related to older people or families, or a tribute kind of thing where, like in the UK, we had like different platforms where people could put their names or sign in or put some kind of symbols. I wonder if we can create something digitally so that we can hear the voices or the experiences of families with older people or older people themselves, so that we can understand the collective, impact it had in India. That's it. These are my thoughts.
Thank you, Aravinda. Any other speakers? Yes, Eric.
I mean, it's important that a digital revolution is taken to older people in rural areas. It's going to be a challenge. It's not because, elderly 60 plus, I mean, almost 50–60% of them are completely illiterate, right? They have no education and they live in remote areas, very extremely. Even the smartphones is not easily accessible for a lot of them in remote tribal areas, remote areas. It's not as easy as, Prashant was giving instances of some success here and there, but not always lost. Majority lives in rural area, remote area. That is one thing how we should plan for this. Second, that Prashant was mentioning that we should work together for this. But if really, if you're speaking, if the government requires to put an enormous amount of resources, for example, just spending less than 1%, that is not something I can do or we can do. The government, everyone has said this for years, for 40 years, 50 years, that we need to spend more money, invest more in healthcare infrastructure. That is when we will become prepared to face this type of crisis, pandemic driven crisis. So that is something we cannot do. I mean, we can get involved in ourselves in a way wherein locally, but there is lots of efforts and resources and management required from the government and the policymakers side. That is very, very important. And one of the important requirement is data, which is really, really, a country like India, we really have that problem, serious problem. Thank you.
Can I just add, it seems that India often has an incredible capacity to collect and process data, often for other countries. So it's not that the capability and the resources are
it's not
there. There's a tremendous irony, isn't there?
Yeah.
But I'd just like to, from an outsider's point of view, that's my perspective at least.
I mean, almost a substantial proportion of deaths in rural areas, whether it's flood deaths or COVID deaths, there's no way they got registered or they got reported. That and we get timely data on those cases. That is the real problem. There are lots of
Sorry, you're on mute now, Arika-san. Hello?
Yeah,
yeah,
sir.
You're back.
Yeah, I personally know there are a lot of people who died of COVID, but they were given signed causes other than COVID, just like a respiratory issue, cardiac arrest, and so on. There were a lot of COVID deaths, which was because they were not tested before. They were just rushed to the hospital, or they just died on the way, etc. So we have lots of I mean, undetected, unreported mortality, and that is really because of this data surveillance system, poor data surveillance system. And I mean, still the government doesn't think that we need hard scientific data in public domain, so that researchers can analyze and help government in correcting the policies.
Well, I guess the question is, why would politicians want hard data when the hard data isn't necessarily something that's going to make them look good? And that's a problem that, you know, all countries face. And so then the question is, who holds the politicians to account to make sure that the data are brought about? And that's very, very hard. It's a catch-22 kind of situation, isn't it? I'd like to offer Nidish an opportunity to come in now. And then I think we've done the rounds of everybody, although if any of our participants have anything else they would like to add, our general participants, please do raise your hand, because this will be your last chance. Nidish.
Yeah, I would like to answer two questions which is raised by the participants. First one was why the lowest investment in public health sector. See, there are a lot of political and economic reasons, but simply I can say that government of India consider healthcare as a commodity, not a service. That's a major reason why we are not investing in public health sector. And the second question was how Kerala with integrated social and integrated social and health services. The state Kerala is famous for its decentralized planning, especially the role of local self-government is very important in development program. So it's all a people-centered planning state government take. Yeah, thanks, Peter.
Thank you very much. I don't see any more hands in the air, so I think we have completed our webinar. Lucas, could you just put up the final slide? I've saved something to the very end, which I think is just nice to share with you. But I've caught Lucas on the hop. Yeah, I love this. This was a tweet put out by the DG of WHO back in February. There is a disturbing narrative in some countries that it's okay for older people to die. It's not okay. That's on the front of the Global Platform site's webpage. And I think you should possibly think of putting that as your own email signatures. I think it's so important in countries like India to use the moral authority of the Director General of WHO to really bring home, and he put this in incredibly direct and blunt terms. Sometimes I'm critical of World Health Organization, but in this case, I think, you know, this is a phenomenally important intervention that was made, and it wasn't picked up by the media. It wasn't retweeted very much. But if you want, I can send you the link in terms of where that statement was made. And clearly that's the case in India, it's the case in my own country, it's in the case everywhere in the world. Thank you so much. As I said at the start, don't know very much about India. I know a bit more now, but I don't know. I've got a lot to go away and think about and to process. Hopefully you have as well. I think it's been one of our best webinars. Very informative, very well, lots of very interesting discussion and debate. I would like to thank Lucas, who works with me to help make this work smoothly. I would also like to thank the University of East Anglia, who provides some funding to keep these activities going. And I hope that we can continue to engage, to build on some of these discussions, to build on some of these ideas, either through the global platform, and I do encourage you to visit our site and to contribute to our site, or just on a more individual level. Thank you so much, and especially to Dr. Shah and to Dr. Chatterjee. I hope you make a full recovery, because that's what really matters. Thank you, everybody, and see you again soon.
Thank you, sir.
Goodbye. Take care.